Every once in a while, you meet somebody who changes how you think about a topic you've been working on for a while. Speaking for myself, the next speaker has done that with regard to health equity. She has found her calling caring for people who have been incarcerated, who are survivors of abuse, and who have been trafficked. It's hard not to think about health equity differently after you read about that lens that she brings to her work and after you learn what she has done. People she works with have been through terrible things, and yet she is the most optimistic and sunny person you will ever meet. And today, she is here to share something new and different with us. Please welcome Anita Ravi.
It's an honor to be here, and it's because what I'm about to do is a big public experiment, and I hope it goes okay because my parents are watching on the live stream. So one of the toughest things, I'm a family medicine doctor, and one of the toughest questions I get asked, and the questions that I dread the most are, what do you do? And I always wonder, like, okay, how can I do justice with explaining the type of care that I do and really make it resonate so that people keep listening? And it's true, a lot of the work that I do, so I run a nonprofit healthcare organization called Purple Health. And what we do is we do free comprehensive healthcare, so that's integrated primary care, mental health care, and care navigation services for survivors of gender-based violence. So our patients have experienced human trafficking or domestic violence, sexual assault, and they may be anywhere in that journey of that experience. So they might be in the midst of it, they might have experienced it years ago, but there's something about their healthcare needs that have kept them from engaging with care that they needed. And that's actually that's the toughest part of explaining things, is explaining the trauma of the healthcare system. And so that's one of the things that I've been like, okay, how can I explain what the patient experience is like for people who've experienced trauma? The other tough part is explaining what I do about it. So I have an awesome team. Today's a clinic day, so I'm gonna say hi to them also. My teammates are Jessica, she's my co-founder, and she's a social worker and mental health care provider. And then my colleague Keisha was my former patient, and she's a survivor leader and care navigator. And we meet and we troubleshoot all the time. Sometimes we spend up to 50 hours figuring out how to get one patient comfortable engaging in care for their first appointment. It takes a lot of work. So I was trying to think, like, how can I summarize what we're doing in a job description? And the term that came to mind is this idea of being a trust engineer. And I think it's right, because I think when you have traumatic systems, you need trust engineering, and you need it in a lot of different ways. So that's what I want to talk about today. And I was trying to think, well, what's the best way to be able to illustrate it? And I know the answer is obvious, but I'll just say it anyway. I figured the easiest way to tell you what it looks like for a patient to go through our healthcare system if they've experienced trauma, and how we can do moves that are engineering trust in their experience, is by using Mario Brothers, the 1985 version. So I just want to talk about what that patient experience might be like with the back show of Super Mario Brothers, the 1985 edition. So you can see right away on the first screen, Mario Brothers has metrics. And so I want to pull your attention to a couple of these important metrics. When I see Mario times 3, I think about, okay, I have 3 tries. Sometimes you're lucky. Sometimes you can only engineer 1 shot to be able to engage with someone in care. Sometimes you might get 10. But when a system isn't designed for you, you really rely on someone's resilience in order to survive the system. So let's say you have 3 shots to engage a patient in care. You have a certain amount of time that the system allows for you to do it, and then there's the coins up there, and we'll get to that in just a second. So let's talk about that first try in the patient experience. So we talk about systems design and trust engineering. The very first question or the very first engagement we have with someone is showing people our values and what we value in a system. I think it's really important. If you take one thing away from this, is healthcare is not the only broken system that our patients engage in. They have a history of systems that we're supposed to help and that let them down, whether it's family court, whether it's the education system or other systems that they were supposed to trust and they tried and it didn't work. So we have to think about that. When we think about the ecosystem of our work, we have to think about the other systems that our patients are engaging in. And if you want to keep them engaged, it might be an important question, but we need to think about where to ask it and what happens after someone answers. It sucks because honestly, some of my patients have Medicaid and it'll be turned off when they come off of, when they're released from jail, and then it'll be turned back on. Half the time it's active and they don't even know it, so they're afraid to use the insurance that they have because of what happens after they say no or yes. Sometimes they have to see a financial counselor before they can actually see a mental health specialist or a primary care doc. So something to keep in mind. All right, so let's try again. Let's say that someone feels they're still approaching with a little bit of anxiety. You could go faster, but you get past that front desk interaction. You answered some questions, you helped the system get money, but now you're faced with these quality metrics questions. And a lot of the things that our systems do is we innovate for efficiency, right? We're like, you know what? We could take advantage of the waiting room time and we could just give people an app and have them answer all of these questions that would help us get our metrics and so we could get reimbursed and it'll be good population health. So we might ask people, any recent ER visits? Because we know, okay, every time I hear people, this is a trust engineering tool that you can use. Whenever people give presentations and they justify why their idea should be invested in, I think about the order in which that they talk about their innovation. And people will say it's because it's going to save the system a lot of money and it could improve patient outcomes. And the order matters, and that is another thing I think you'll see here. But patients notice that too. And the thing is, we've heavily invested in these overutilizers, the high utilizers of care. They cost the system a lot of money. And we're like, okay, there's other ways that we can get them engaged. They're not using the ER a lot. I work with people who are underutilizers, and I don't know who's innovating for them. They're people who need care. When I talk to them, they don't trust the ER to go in and get the care that they need, and that's a problem. And I say that here because I strongly believe that there are solutions and there are people who are motivated to be able to answer that question as well and do it in the order that matters. So we have that, and then we have the PHQ-9 related questions, the depression screening. It's evidence-based when you say, any thoughts about hurting yourself or anything like that? And then we've engineered even social determinant of health questions, right? But patients kind of give me the backstory on how they answer these, and I'm telling you because you're collecting the data and you're making decisions based on data that you feel is largely accurate. My patients will fill out the PHQ-9 and they'll be like, no, Dr. Ravi, I'm putting 0 for everything. Because the last time I answered honestly, I was put into a psych ER, I didn't want to be there, it was terrible. So you know what, I'm just going to skip that. It's like, okay, but someone is making decisions based on how you answer the question to survive the system. Then the social determinants of health, look, that's great. It's great that we're doing that. But a lot of our patients, if we think about addressing social determinants of health as a treatment, we have to think that some people have been here for a long time and they've experienced a lot of systems and they may be treatment resistant. You hand them a sheet of every single shelter they can go to, they've tried it and they've been kicked out of shelters every 3 months and they know and it won't. That solution doesn't always work for that person, but it's important to know because when you juxtapose that question with the first one you asked, which is how are you going to pay for today's visit, and you're also asking them about their rent, people can't reconcile what your goal is in their care. And so I think the order is important, the intention is there, but the way we execute it really matters. So this is some trust engineering stuff that we've been doing at Purple. One of the first questions we ask people at check-in is, do you want some water? The reason I say that is because it's twofold, right? It could be a long day, it's just a nice thing to do. The other thing we started to notice is people would be working, they'd maybe come in after an overnight shift or they haven't really been hydrated and they're gonna get labs. They rarely get in contact with the system. You have them, this is like your one shot to be able to do the things that they need and that they want to do. But it's so hard to find a good vein because people are dehydrated. And that's not trauma-informed if you keep poking at people multiple times. So we let people know, do you want to drink water? If there's a chance we do labs, it'll make it easier. Something like that, so people know that the intentionality is around them and their needs and what we could do for them. Similarly, would you like to charge your phone? Every single question is important on the timing of where you ask it in the interaction. You can ask all the ones that I asked before, but at the end of the interaction, it might make more sense than perhaps what's most efficient, which might be in the beginning. So this one, do you need help accessing your results? So literally everyone in the innovation space is almost equivalent for saying, we have an app for that, we have an app. My patients don't have a phone for that app. That's a problem. Some of my patients call from those street phones that we have to say that they're going to be running late for their visit. I spend so much time, and our care navigator spends so much time helping people get their password, get login. The democratization of data for people to be able to access their results is not truly democratic if they don't have the tools in order to be able to access it. And that's where we are trying to invest time to bridge those gaps, because we know that no one is innovating for the people who don't have phones or a consistent phone. And I'll give you a small pearl. One thing that you might want to do if you're really trying to understand the stability of a patient, ask them how long they've had their phone number for. We opened our new clinic in October 2021, and our patients, some of them have had at least 6 phone numbers during that time. The consistency and the ability to be able to count on basic things that we do to call results, to get pharmacy and other stuff, it's so important to think about people who we're not designing for, or norms we take for granted, so put that there. And then finally, as a trust engineer, you want to understand this question about emergency contact. I could talk about this forever, so I'll do it at the salon. But the emergency contact, it's so interesting for the patients that we see. Often they'll put their lawyer, or they'll put a social worker. They might put an abuser. And we go out of our way to always ask at the beginning of every visit, is this still your emergency contact? Because trust changes. People may trust us differently based on the interactions, but they may trust the people that they're working with differently each time too. And some system that they trust, maybe they don't trust their lawyer anymore because something didn't come through on court. But we need to know that because it's essential for how we deliver their health care. All right, so we'll keep going and we'll follow up on the visit. So we talk about pain points in medicine, and there's these small moments that can invisibilize you in a system. And we talk about protocols, and weight is one of them, actually. So there's a large linkage between history of trauma and disordered eating. So whether it's obesity, whether it's anorexia, bulimia, whatever it might be. But sometimes that protocol and the way we do it and the order in which we have to do it can invisibilize people, because that interaction is what they're dreading. They might come in for a rash, but they're like, nope, we got to take your vitals. But that may not be a vital sign for a patient. So what I do sometimes is I do it backwards. Sometimes I'll see them and then let them know, okay, I need your weight because of this, or whatever it is. Again, the invisible thing in the room that we're fighting sometimes, I think, is efficiency. But I think in order for us to re-earn trust, sometimes you have to change the norms in order for people to be seen instead of invisibilizing them. All right, so we're about to have the patient interaction with the physician. So the 15-minute visit. This is important because people always talk about the difference between equality and equity, right? 15-minute visits for everyone is equality. Customized visits based on your need is equity. It's based on what that person needs. So trust engineering involves math. And somehow someone did math and they were like, if you add an extra person, you can actually make this more efficient. Like having 1 + 1, having a doctor there and a scribe could actually make it so that you don't have to look at the computer, you could look at your patient. It's gonna be great, like burnout levels and all of those things. But the thing is, when you talk about sensitive issues, it's not always adding someone sometimes can subtract trust. If someone wants to disclose something or talk about an issue that they might be having or that they have shame around, having 2 people there can sometimes make that interaction so much harder. And it's funny, one of the patients that I talked to were talking about this presence of a human scribe there so that your doctor can look at you. She's like, it seems like that court stenographer that I see in court all the time who's sitting there just typing. And I was like, oh my God, people see other systems that they've engaged in the ones that we're building. And that is just so important to recognize if we really want to engage and see people who are invisibilized in our system. All right, so we have one last try. And this is aftercare. Let's say that the visit went well, but now you've got all the follow-up stuff. Pharmacy, specialist, imaging, labs. And that gap in care is, I know people were alluding to it earlier this morning, that is so important because sometimes the nidus of control ends at that visit. People have so many other ways, right? Whether it's pharmacy pickup, people were talking about that earlier today, the ability to have imaging, specialists, labs, all those things. People are collecting data on who uses that, and then we come up with best practices. If our patients can't make the jump into getting access to all those things, they're getting invisibilized in all of the follow-up care that happens in primary care. So, the thing is, if any of you actually really enjoy Mario Brothers, this is the best screen in the game. And here's why. This is where all the potential lives. So you're in the first level, Mario 1-1, and yes, there's a giant gap. But the thing is, there's solutions. We just have to decide whose responsibility is it to fix that gap. There are ways that we can do it, and there's ways we've experimented at Purple, but why even have a gap to begin with? There are ways to make it so that people don't need to learn how to jump it, they just have to walk it, and we can help them. All right, that's fine. But the really cool thing about this is there's access to invisible solutions here if you ask the right questions. So what I think I'm finding in clinic is often I go against what best practices are. If someone comes in for a rash, I just look at the rash, or that's what they tell you to do, right? They're not look at your ears, do a full exam because we don't have time. That's not really the best practice. But I make sure sometimes for my patients to be able to do that because they don't often get head-to-toe exams for what they're doing. And all of these different trends start revealing themselves. One of them is traumatic brain injury. So sometimes I have patients come in and they're like, God, I'm such an idiot. I forget things all the time, things are so fuzzy, or I'm sad, and so we'll put them in therapy. But the thing is, if you take a good history and you understand and you look at different pathology, you start to see, oh my God, this is much more similar to what an NFL player experienced than it is for someone who's been chronically depressed. That changes the outcome. That changes the type of care plan that I'm going to come up with, but we miss those things if we don't spend time. So you have to have the curiosity to figure out these, what I call, one-up moments. These times where it's I'm going to discover something that actually could change the field if you have enough time and curiosity to figure it out. So that's one thing. The other thing, though, is this opportunity to collaborate with the people that you are creating the metrics for. So one of the things is if you do trust engineering correctly, you can actually start finding out from your patients the things that matter to them and what are the things we should be measuring and what do we want to measure. So I'm going to leave you with this final clip, and this is what it could look like. Whether that's discovery of new primary care, best practices, whatever it might be, collaborating with our patients, one of the things we do now is we actually start asking patients, do they have a bank account? Can they keep their minimum? Do they know their credit score? Because we understand that it's not just about avoiding medical debt, it's about helping people build wealth. And medical care can do that. Healthcare systems can do that if we think beyond the silos we live in. So we can get to this final point where patients are able to actually meet the goal that they're looking for. And the way we define that goal is where the system meets the patient's quality metrics. And I hope that this is a helpful example for how we can engineer trust into the people who are invisibilized in our systems. Thank you so much.